All right. Hello, everyone, and welcome to our Grand Rounds event today. Whether you're joining us in the Rangos Auditorium or somewhere else virtually, we thank you for taking time to attend this special presentation. As a reminder, for those that are virtual, there is not a separate link for the meet and greet today. The meet and greet will be integrated into the lecture at the end. If you would like to ask our speaker a question of any type, please type it into the Q&A. If you would like to engage with the presenter, ask the webinar host to unmute or give you access to turn on your camera. If you are attending in person and would like to engage, just raise your hand and we will bring you a mic. We also have posted the QR code for today's MOC2 quiz on the back desk by the door for those of you who are attending in person. We are honored to have Dr. Tony Pizon speak with us on addiction and implications for pediatricians today. And it gives me a great deal of pleasure to be able to introduce Dr. Pizon. I've known Dr. Pizon for quite some time. And I think most of us would agree he is an incredible person. Dr. Pizon received his medical degree from the University of Toledo School of Medicine in 2001. He then completed his emergency medicine residency at the University of Pittsburgh Medical Center in 2004, and his medical toxicology fellowship at Banner Good Samaritan Medical Center in Phoenix, Arizona in 2006. Dr. Pizon is currently a professor in the Department of Emergency Medicine, Division of Medical Toxicology at the University of Pittsburgh School of Medicine. He serves as chief of the Division of Medical Toxicology and director of the Medical Toxicology Fellowship at UPMC. He is also assistant medical director of both the Pittsburgh and West Virginia Poison Centers. But most importantly, he is a good friend. He's a great physician. He is blessed with an amazing wife, Karen, and 4 wonderful children, Benjamin, Elizabeth, Gabriella, and Serafina. And it gives me a great deal of pleasure to introduce Dr. Pizon. I'm giving him a hug.
That was like the best intro ever.
Could have roasted you.
You did want to roast me. The funny thing is, I heard there was a little battle of who wanted to introduce me. It was either Ray Patetti or Ryan Gosling. And I'm just glad Ray won, you know, the guy with the best 6-pack. So no, thank you I'm honored to be here. Thank you for having me. Please chime in with questions. We can keep this informal or what have you, because there's so much to talk about with addiction. Particularly how it applies to pediatricians and what you're dealing with these days. So the big things to talk about is basically what our new normal is for drug use, because it's changed from back when Ray and I were in high school. Things have changed, you know. Sorry, Ray, I'm going to pick on you the whole time. Review a little of the epidemiology, talk a little bit about the biopsychosocial contributors to addiction, particularly how it applies to pediatrics, and then what can we do? What can we do about all of these shenanigans? So the new normal is a bit different than what we've experienced previously. Back, you know, in the day, you'd have a poppy field, you know, you'd grow your poppies, extract your opium. Now, most of the drugs are chemically synthesized now, you know, sort of that Breaking Bad model of chemically synthesizing them and shipping them. And it's truly the model of it fits, it ships. And in China, largely the chemical synthesis happens there, and then it somehow makes it across the border here to the United States. So that's the typical process these days. So much so that even the United Nations has come up with a term, and you'll see this term in news media and the CDC and the Drug Enforcement Agency. They use this term new psychoactive substances, or NPSs, regularly to kind of describe these things, because there's so many new products, and we'll go in a little more detail about this. But basically, it's impossible to track, it's impossible to police, and it's making our lives as physicians a little bit more difficult, or maybe intriguing, depending how you look at it, I guess. So this is an example. So the DEA every year, this is from 2020, the most updated list. This is what they call the emerging threat report that DEA puts out. And these are all the different opioids that are confiscated from Ray Patetti's backyard. No. Sorry, Ray. You were so kind, and I'm just going to land-based you now. But you know, the most common obviously is fentanyl on the bottom, but then look at all the different chemically synthesized drugs that are available: 4-ANPP, acetylfentanyl, carfentanyl, valorolfentanyl, butyrolfentanyl. I mean, the list is endless in terms of what we're identifying and finding these days. So, you know, heroin, we still call it heroin, but we don't really see heroin anymore on the streets in Western Pennsylvania. And so today's hearing, and part of the issue with heroin is the potency is very variable. So you're not really sure what you're using. It looks very similar. It could be anywhere from carfentanil to acetylfentanyl to fentanyl in the middle. So the potency and the variability is quite great. And I think one of the other big issues are these pressed pills. You know, in the news media, these sort of like candy looking pressed pill tablets was making a lot of press. Fortunately, we have not seen anything like that in Pennsylvania yet. But I think one of the issues particularly with children is when children are experimenting with drugs, they're more likely to take a pill from a friend that they think is just a pill. Like, oh, mom and dad takes this. This would be okay. I just an oxycodone. How bad can it be? Well, it could be a pressed fentanyl tablet instead that looks identical. And in doing so, you can have a drug that's maybe 100 times more potent, and then the kid's dead, you know, or severely ill or what have you. So I think, you know, the pressed pill thing has really changed, you know, how kids approach things too. Benzos. We are in Western Pennsylvania also a hotbed of benzo use. And so we see a lot of these illicit benzos too. And these are benzos you've never heard of before, like fluoprazolam, etizolam, clonazepam, not clonazepam, but clonazepam. So even illicit benzos and chemically synthesized benzos are very frequently found. And just like the opioids, you know, these are Xanny bars. For those of you who aren't aware, it took me a while. I'm kind of a dweeb. I know it's hard to imagine, right? I learned all my knowledge from my patients, but like, why are they called Xanny bars? Why, you know, this is why they're called Xanny bars. So Xanax comes in a bar, right? But you can get pressed pills that look like Xanax, and they're maybe not Xanax. They may be fluoprazolam. They may be fentanyl, for all you know. So this is not uncommon with the benzos as well. And because a lot of these chemically synthesized benzos and opioids are not FDA regulated, you can buy them technically, you can buy them legally online, you know, from chemical distributors. Like Chemical Frog is one of my favorite places to go, right? So you can buy tizolam. You could buy as much as $10,000 worth of a tizolam online pretty easily. And truly, like I said before, it fits, it ships. You can have it shipped right to your house without much of an issue. Cathinones are another popular thing that we see too. Cathinones are the new stimulants on the street, right? And I'll talk about those in a second here. But cathinones are the new stimulants, and there's all sorts of different ones out there. Cathinones are derived, synthetic cathinones, from the compound in the top left-hand corner. Really the difference between that and amphetamine in the opposite corner is that double bond O. And there's not really much clinical difference. It's just that a lot of these drugs aren't DEA regulated, so they can be chemically synthesized and altered. You can put side chains. You know, Molly or ecstasy, Molly is the street name for ecstasy, which is that middle compound, MDMA, is what we used to see. When adolescents are using Molly at rave parties, it's usually methadone. Not a clinical difference, but it's just chemically synthesized in that way. And the pharmacology of all these amphetamines is very variable. Like MDPV is super long acting. So when people get an MDPV, we're often intubating them and sedating them for a couple of days because it's just that long acting. So you get very different kinetics, but that's just what we're dealing with. I can't not mention cathinones without mentioning Wellbutrin or Zyban or bupropion. Bupropion is a great antidepressant, but we see a lot of issue, particularly with more college-aged kids, using Wellbutrin to help them study. They'll crush it, they'll snort it, they'll use it, they'll sell it, they'll trade it to get through exams and so forth. We see a lot with our Pitt and CMU students. It's also known as prison meth on the street. So there is a value to Wellbutrin on the street too. So it's a great antidepressant. And then last but not least, synthetic cannabinoids. Sorry, it's hard to hear my echo. The synthetic cannabinoids as well. Fortunately, it kind of goes in waves in terms of how bad the synthetic cannabinoids are making their effect, but those are another issue. So that's kind of the new normal in general we're dealing with, but I can't not talk about the new normal without incorporating marijuana and how marijuana has changed too, because marijuana is becoming the next big thing, or has become the big thing too, that we're seeing with particularly with children. So, you know, and it's funny, I feel like marijuana has this sort of, I don't know, dichotomous life, if you will. Like on one token, you can have the California Narcotics Officers Association talk about, there's over 10,000 documented studies available that confirm the harmful physical and psychological effects of marijuana, right? Maybe it's a little hyperbole, but not completely untrue, right? And then other, my weekly reading is from, Cannabis in Medical Practice, good journal if you guys are looking for something with a really high impact factor. But marijuana has therapeutic benefits and could ease the suffering of millions of persons with various illnesses such as AIDS, cancer, glaucoma, and multiple sclerosis. Again, maybe a little hyperbole, but not completely true. But we have this sort of ongoing battle back and forth. Is marijuana good? Is it bad? Is it ugly? Is it different? I don't know. But so much so that when state by state, when we began to decriminalize and legalize marijuana, the Obama administration actually sat down with the FDA and said, hey, what should we do about this on a federal level? Because obviously the states are taking this in their own hands. What should we do on the federal level? And the FDA researched this. There's a huge document that they put out concerning this. And basically their conclusion is that marijuana is not safe and effective drug for any indication, which is interesting. But that was the conclusion they came up with, okay? It's still a Schedule I, and Schedule I just means it has a high potential for abuse and no really accepted medical use, which again is maybe a little not completely disingenuous or what have you, because the difficult thing with marijuana specifically is that we pick on 3 cannabinoids and talk about these 3 cannabinoids a lot: cannabinol, cannabidiol, or CBD, and THC. But in marijuana, there are like 60 different compounds in marijuana. And if you go to your bud tender, not maybe the most professional way of identifying these people, but they are called bud tenders. When you have a marijuana dispensary card, you go to the bud tender and help you pick out which medicinal marijuana cultivar you're going to use for your ailments. And they'll base it off of, what the constituents are in the marijuana to help treat your medical ailment. And there are lots of different compounds of marijuana, lots of variability in what you get. So I can see why it's difficult to really make marijuana, the plant, the substance, medicinal. But we do have medicinal marijuana, if you will, right? And for many years, we've had Marinol or Dronabinol, if you guys ever use this, maybe more in adult population. But the funny thing about Marinol or Dronabinol, it even says on that label there, synthetic marijuana. Dronabinol, the generic, is really chemically synthesized THC. So this is just THC. It's obviously one of the 60 compounds, but it's THC and it's used for anorexia. It's used for nausea, vomiting associated with chemotherapy. So we do use some of the components of marijuana medicinally too. And Epidiolex, one of my favorite words is I just like saying Epidiolex. But CBD medicinal again for seizures, particularly in pediatric patients. Just a couple of years ago, Epidiolex kind of reared its head in terms of indication. So we do use some components of marijuana for treatment. But the real problem is this sort of patchwork quilt of medicinal and recreational marijuana use that we have across the entire country. And this is a few years old, but basically it holds true today in terms of the variability in terms of the legality or decriminalization of marijuana across the country. And because marijuana is illegal on the federal level, you cannot get on a plane and travel, right? I mean, there's a professional basketball player who's stuck in Russia because she was carrying marijuana, among other things with her. So you cannot travel with it. If you have any profession that requires drug screens, like medical residents, when you get hired, you cannot use marijuana. I don't care if you have a medical marijuana card, right? You still cannot use marijuana. So we've, unfortunately, I know we just had an election. We unfortunately have taken FDA out of the picture and medical doctors out of the picture and made politicians decide what's best in terms of legalizing marijuana. They want to decriminalize marijuana. That's one thing. But really, we're making marijuana kind of medicinal, but it's really not. We're saying it. You don't get a prescription when you get your medical marijuana card. You're getting a medical marijuana card. The wording is very different. And you go to dispensary and you get as much as you're willing to pay for, and you can use it as you need to for your whatever ailment is. So it's a very different process. And we've kind of normalized marijuana, particularly for our children, which I think is a little bit unfortunate. For example, one of the things I'll talk about a little more, the Colorado experience, because they were one of the first to legalize marijuana. But Kansas, right next door, has much more strict laws concerning the legality of marijuana. And though the marijuana grown in Colorado needs to stay in Colorado because it can't cross state lines, there's a large percentage of the marijuana grown there that is not used there. No one knows where it goes, but a large of it probably ends up in Kansas. So we really changed the marijuana market, right? It used to be just like you knew the guy to get your marijuana from illicitly and who to go to, right? But now there's state-approved recreational use in some places. There's state-approved medical use, like in Pennsylvania. And so it makes policing marijuana very difficult, and the availability goes up, right? And if you think about it, like in terms of handgun safety or other violent issues, I mean, if handguns were placed everywhere, of course, it'd be easier for people to harm themselves, right? No different than with marijuana. You know, we're making it more available for our kids. We're making it more normative that we can use marijuana. And so my dad uses it medically, so it must be okay. The other interesting thing about marijuana is it's not the marijuana that Ray and I used to smoke back in the day, right? You know, so sorry, Ray. Sometimes you just got to know. People need to know. But the green line, you can buy concentrated marijuana products, which is kind of interesting, right? And the concentration of those concentrated marijuana products have really escalated over the years. But I think even more important is that gray line. It looks more subtle, but that gray line represents the average THC concentration in marijuana plant products. And back in the 90s, the average concentration of THC was right around 4%, like 3.5 to 4%. And now we're pushing 14%. So it's like a 3 or 4 time fold increase in the THC concentration. So the marijuana that we're using now is very different than the marijuana back in the day as well. So it's interesting. We've learned a lot from the Colorado experience. Matter of fact, I was sort of the stance back in the day that, you know, maybe we should just legalize marijuana. You know, it's sort of social. It's like alcohol. What's the big deal? People use it socially. But we learned from Colorado, because Colorado truly decriminalized it on a recreational and a medicinal level back in 2012. But they stopped really prosecuting marijuana in 2008. So you'll see a lot of the changes occurred in Colorado as early as 2008 because they stopped criminalizing marijuana use. And so it's legal in Colorado to have up to 28 grams of THC containing products. And a joint, if you will, is about 1 gram of THC. So, I mean, you can have a lot of marijuana, keep you going for a few days at 28 grams. But in 2015, they noticed a huge increase in terms of pediatric ED visits associated with THC use. And most of it, this won't be surprising to people in the room, was really associated with edibles. And we're seeing that too a lot with our pediatric population, you know, in terms of the edibles that are available and what kids think are good and bad. This is dad's special brownie, not a real brownie, if you know what I mean. And these are ED visits in Colorado over the years. Like I said, they stopped criminalizing or began decriminalizing marijuana about 2008. So that's when you start seeing the increase in ED marijuana associated visits or healthcare, behavioral health related visits, pretty steadily increasing over that time frame. And I don't know if you guys have ever seen any of these, but they really don't look much different. I mean, I wouldn't hardly look at this. I mean, gosh, we got Halloween candy coming out of everywhere in our house these days, like Stony Patch Kids, you know, brownies, sour gushers. So it's easy to mix this up. And I feel like a lot of the issues that we discover with, you know, maybe the older children who get into these, they take 1 or 2 and they realize these don't taste right. Something's not right about them. Then that's when they reckon it, but it's almost too late at that point. Because I mean, if you eat candy like I eat candy, it's going down pretty quick. So something's not quite right. So that you can see how this could be a big issue for children of all ages. But with this, it's now become the most commonly used illicit drug in the United States and most commonly used illicit drug in children as well, which is interesting, right? So the whole marijuana perspective has changed. So only 1 in 5 children perceive any risk from marijuana. They say, oh, how bad can it be? You know, my dad used it. We normalize it. It's okay. It's medicinal, you know, sort of like that pressed pill. The kids will feel comfortable taking a pressed pill because they think it's medicinal rather than snorting a line of cocaine. And 9% use marijuana regularly. which is like an 80% increase from 2008. So we won't go back and look at the 70s and what was going on back in the 70s, but you can see now, I love this study from the University of Michigan, one of my favorite colleges. I know some kids go there, some great doctors' children go there. Not Patetti's kids yet, no. But perceived the use of marijuana is escalating. This is from 2013, but it continued to rise, and then the perceived risk is decreasing. So risk and use are sort of like, counteropposed to each other here. And what I found interesting about this as well, right? So we've done a great job of discouraging children from using cigarettes, but we're just replacing it with marijuana. So, maybe like 10-ish years ago, marijuana has superseded cigarette use in our high schoolers, which is very interesting. And again, this doesn't seem like a huge increase, but this is basically the rise of past marijuana use in kids from as young as 12, from 11% from 2002 to 2019 to 17.5%. So there's been this gentle increase in past marijuana use in our children. But the bad news is there's lots of evidence that show it's terrible for kids, right? So when you look at long-term outcomes, they have poor education, employment outcomes, poorer cognitive incomes. It actually decreases their IQ, believe it or not, for kids who use marijuana in their adolescence. Increased likelihood of motor vehicle collisions. It truly increases the risk for other addictive issues down in the future too. And we know it causes both acute psychiatric illness, like we see more acute psychotic reactions associated with marijuana use, and it increases the risk of long-term psychiatric illness as well. So there's lots of implications for marijuana. And again, this is just a new normal we're going to have to deal with in terms of marijuana, its prevalence out there. It's just unfortunately the way the tide has changed over the years. So where has this new normal brought us? I guess the short answer, it's a good time to be a medical toxicologist or someone in addiction, right? We've done an amazing job of keeping people safe. Bicycle helmets, harnesses in cars, child restraining devices, you name it. The overall motor vehicle traffic, unintentional injuries and deaths have really gone steadily down. Drowning, falls, unintentional accidents. We've done a really great job. But unfortunately, overall, unintentional injury and deaths have really skyrocketed, largely led by poisonings over the years. And that rise in deaths is really driven by the opioid epidemic that we've been dealing with for a long time. So these are just the most recent numbers from the CDC. 70,000, over 70,000 people have died from opioid related deaths or overdoses in 2019. 10 million people misused prescription opioids. 1.6 million people had an opioid use disorder in the past year. So, this is no small peanuts. This is just the United States over the last year or so. And this has been going on for many years, even as far as the 80s. I like this graph only because it's sort of like the shock and awe, like exponential growth of overdose deaths from the 70s to 2016. It's really quite increased. And it spans a lot of ages, from people as low as their 20s up in their 60s. It really spares no race, no gender, no age group. So it's really been quite the exponential increase in deaths. And these are U.S. drug overdose deaths. More recently, this is the sort of increase. We maybe are leveling off a bit, maybe turning down a bit, which would be nice. But there's really been no shortage of drug overdose deaths. And specifically Pennsylvania, it's interesting. We had this really steady increase in 2017 to 2018. We went back down. Then COVID made it really easy, and a lot of boredom set in with COVID. So we started seeing a rise again with the onset of COVID. It was interesting. People, it was much easier to find drugs in our COVID era when people were on lockdown, and we sort of stayed up there and plateaued. And hopefully, we are again coming down. But Pennsylvania is no shortage of drug overdoses here. And this is not red blue state. This is just like a heat map of, and we in the eastern part of the country, Western Pennsylvania has been a hotbed of opioid use and misuse for many years. Matter of fact, friends would ask me, we had these fentanyl outbreaks called China white outbreaks. as early as the 80s, and people, oh, what's it like to have these fentanyl outbreaks in Pennsylvania? Oh, that's interesting. And now it's just all fentanyl everywhere. So it's interesting how times have changed. So why in the world do people get hooked on these drugs? Why in the world does this happen? I mean, there's a multitude of issues of why children get hooked on these, why adults are hooked on these. And it's really kind of a complex thing. I can bore you to death for hours about this. Ray Patetti would just eat it up, right? but there is a genetic component to it. So there are genetic first degree relatives. We know this from alcoholism, but we now know this for opioid related addictive issues too. There are genetic components. So if you have first degree relatives with some kind of addiction, your children are more likely to as well. So that's something you should keep in the back of your mind. There's a lot of psychosocial stuff, and we're going to talk about that probably ad nauseum here. But we're increasing the availability of drugs, the physical, psychological trauma that children go through a lot of times. There's a lot of impaired coping. A lot of adults use drugs as sort of their own personal coping mechanism. I'm going to go home and drink a beer. I'm going to go home and have my medicinal marijuana. I'm going to go home and have my fentanyl. And so kids kind of learn these behaviors too. And the pharmacology of these drugs too, the prescription issues, people get hooked on them through prescriptions or some other avenues, and it really changes the brain rewiring too. The best example is coffee, and I'll use that as an example in terms of why people are hooked on these even after they get stuck on them. There are pharmacologic reasons for that too. So is it nature versus nurture? Basically, there's some really interesting dizygotic and monozygotic twin studies that they basically show as, somewhere about a third of the attributable effect is genetics, a lot of environmental factors, and a lot of non-family environmental factors like, stressors outside of school, peer pressure, the community attitudes about marijuana use. So there's lots of other factors that kind of play into the whole development of addiction. Okay, this is all the genetic targets. There's lots of genetic targets that people are looking at. And so the neuropharmacology of drug addiction is interesting too. So keeping people off the opioids or drugs is super important. I could talk to you about ad nauseum about this as well, but dopamine is sort of the big neuroreceptor I want to talk about the most, because that seems to be the most salient one to talk about. But there's a lot of neurotransmitters that are involved with this. And dopamine is that feel-good receptor, right? That's that receptor that rushes in your brain every time something good happens, right? So, and with this cycle of addiction, you wonder, like, why doesn't this person just stop their addictive proper? Why don't they just stop, right? Because, you have that episode, you binge on whatever your favorite drug is, alcohol or benzos or opioids or wherever your drug of choice is, and you get that dopamine surge that makes you feel good, right? And you keep going back and you keep going back, but you don't get that same dopamine surge with each subsequent use. So you keep going, you keep looking for that dopamine surge and you don't get it. So then you stop, right? And you stop and you go into withdrawal. But then you go back to using because you don't like going to withdrawal. So you use it again. Or you have this sort of preoccupation of always thinking about wanting to use, and I'll kind of go into the details. It's this endless cycle of going back and just trying to break this cycle to kind of break that cycle of ongoing addiction and use, right? So the mu opioid receptor, for example, really increases dopamine release, right? And it really rewards the person for their use. So if you get an opioid for your broken bone or for some kind of ailment, your toothache, what have you, you feel good. My dad, this is back in the Demerol days, right? When he had his hip replaced, he's like, wow, I can see why people get addicted to this stuff, right? It makes you feel good. And why we got rid of Demerol, because there's so much euphoria associated with Demerol specifically that you go to it and you want to keep going back to it. And it's hard to get off of it. And then you have this sort of ongoing reward to use again and habitually go back to it. And some of it becomes habit. I think my coffee use, I think a lot of people use coffee, can maybe use as an example, right? What's your habit in the morning? My habit is don't talk to me till I get my coffee, right? I got to have my coffee. That's my routine. So I even have moments where I can stop coffee for a little bit, right? I stop coffee for a little bit, but then that habit is like in the morning, I just love the coffee. I love the warmth of it. I love the drinking. I love the smell. There's all these habits that go into it. And some of those habits are what drive people to go back. They really have to stop breaking the habits of who they hang out with, certain smells, certain locations, certain things they do to kind of break that kind of reward. There's two pieces to this. There's sort of the impulsive use, like I'm going to do something impulsive without thinking about the negative consequences. And that's often what people do early because I'm looking for that dopamine surge. And then after they're impulsive, they can become compulsive about it. And I'm sort of in the compulsive era of my coffee drinking, right? Like I'm always thinking about it. I got to have my coffee. Ooh, how many cups did I have this morning? Only one or two. Ooh, I better have another one. I'm going to give a big lecture today. I better, you know what I mean? Like, right. You think about that all the time. I got a lot of patients to see. I better have more coffee, right? I mean, just think about like what you do on your daily basis. And that's what happens, the compulsiveness of the drug use. And then the other interesting thing is, when you really ask somebody who has a lot of insight, why do you keep using when you have so much, you have family, you have this, you want to go to college, you want to excel in whatever athletic event you're doing, or what do you want? Like, why do you keep going? Well, because I don't want to feel sick, right? And again, we'll use the coffee as an example. Like if I don't drink my coffee, I'm gonna have a terrible headache, right? So even if I want to stop drinking my coffee, I'm going to feel tired for a few days. I'm going to have a headache for a few days. But to the patient, they look fine to us when they're in bad opiate withdrawal, for example. They look fine, but they feel like they have the world's worst flu. And that's all they can think about is getting back on their opioids. So a lot of times they go back to using because they just want to feel normal, right? Like I do. I want to feel normal with my coffee use. I just want to feel awake. I just want to feel like I'm contributing. I don't want to be puking my brains out. I want to like go to work, but people just want to feel better. So not going into withdrawal ends up being the large reason why people get stuck on these drugs, unfortunately. And again, the preoccupation of this. And the important part about this too is the stress response too. A lot of children are under a lot of stress these days. There's a lot of anxiety, and they learn from their parents that they cope with their stressors by using drugs. So I'll use drugs, and they rewire their brain in such a way that it actually changes their stress response as well. So that cortisol levels go up when they're off drugs and they go down when they're on the drug. So they keep going back on the drug because it helps alleviate a lot of the anxiety. We've created a lot of anxiety, unfortunately. There's a lot of stress in kids' lives these days. Yeah, so this kind of just rehashes that whole idea of, the impulsive, the compulsive thing that I mentioned about earlier. So this, I like this study. This was done out of Kaiser Permanente. It's not the most recent study. It may be, 8 or so years old, but I like it. And I'm sure the child advocacy people like this article too, because basically they surveyed adults looking back at childhood. And they call them adverse childhood experiences and how these adverse childhood experiences affected health long-term. And they looked at a bunch of different things. They looked at emotional abuse, physical abuse, sexual abuse, looked at household challenges too. Like how was your mother treated, substance abuse in the household, mental illness in the household, parental separation or divorce, incarcerated household members, and then also neglect too, in terms of all these adverse childhood experiences. And the funny thing is they kind of lumped them in 7 big categories, but the most common adverse child experience was related to drugs, was drug use in the house. That was a quarter of the kids who had an ACE, as they call 25% of the kids who had an ACE, it was a drug related issue, so that's in my mind, a low hanging fruit of an area that we can really, really attack right now. So, and when you look at ACEs or adverse child events, 8 million children are living with an adult with substance use disorder. That's no small peanuts there. Parents with substance use disorder are more likely to physically and sexually abuse their children. And the incidence of parental drug and alcohol use really has doubled over the last several years as well. So neonatal absence has gone up. So there's lots of drug use in terms of what our adults are dealing with that's really affecting our children as well. And then the interesting thing is, if there were 4 or more ACEs in a child's life compared to a child who had no adverse child events, your odds ratio for alcoholism, your odds ratio for IV drug use was way escalated compared to the general population. So we're teaching our kids to use drugs as adults. I mean, and those of us who have kids, you realize they learn a lot from watching their parents, right? They learn a lot. I mean, where'd you learn that word? Oh, yeah, you learned it from this guy, right? I mean, it's the silly little things that you do. You learn that pretty quickly. And I found it interesting. It wasn't just, the risk for drug use, the risk for early death went up with all these stressors in life. So they found a strong greater relation between the breadth of exposure to abuse and household dysfunction during childhood and the multiple risk factors for several leading causes of death in adults, which is kind of interesting. So how stress, anxiety, trauma, and PTSD and so forth lead to worse outcomes across the spectrum. Some people would say that the leading cause of morbidity and mortality in our life is trauma. Is really trauma, and that's something that we can attack. So what can we do as pediatricians? These are the Pizon kids. Aren't they so happy? They had the most wonderful dad. Their only dream to have like Ray Patetti as a father, but no, this is at me after yelling at them, settle down, sit still for a picture, for crying out loud. But anyway, but what can we do? There's lots of different things we can do. I think one of the places we can start, you could probably start with parents. There's things we can do with our children too. But we've done a lot of issues through the Poison Center to help with pediatric opioid exposures too, because that's sort of a low-hanging fruit, right? Screening children for the presence of opioids or dangerous medication in their house. The Cole Safety Center is a huge thing here at Children's in terms of providing the opportunity to help like lock down medications. It's amazing. It's particularly the grandparents maybe who aren't as used to kids being around, but how families will leave medications around. I mean, the common denominator that I see a lot is, oh, I just left this out for a second. I didn't think little Jimmy or little Susie can get into it so quickly, but they find it. And if it looks like candy, believe me, they're going to take it, right? So locking medications, using Mr. Yuck stickers, having an action plan, having Narcan available. I know we haven't thought about that often in children a lot, but having Narcan available can be life-saving for these kids. It's sort of, and I'll show you, sort of the AED of drug use. So we have a lot of substance use referral programs, particularly with WIPIC and some of our centers of excellence to, kind of get people linked in to drug use issues. I mean, because we are seeing a lot of children who come in with parents with addiction. Fortunately, a lot of the parents are tied into resources, which are good. It's just they need to keep their medication locked down. Law enforcement collaboration, medical trainee education, drug take back. I mean, a lot of people love to hoard those Percocets. Those like, I had this dental issue. I'm going to say, maybe I'll need it next time. But man, when little Jimmy is in high school, he may be curious about, oh, let me just try that. And that can lead to issues. So there's no reason to keep that in the house, right? And we know methadone and buprenorphine programs particularly for adults and even in kids is really good because you're not just replacing one drug from the other, right? You're trading an illicit drug for a medicinal drug. You're really kind of changing not only the neuropharmacology of the brain, but you're breaking habits. So part of the treatment is to break habits, because the idea when you're using drugs is you're always looking for that high, that dopamine surge, you're going back to it. The idea of methadone and buprenorphine is to use it once or twice a day. I'm going to use it on a scheduled basis. It's going to help configure my brain with my cortisol levels and the dopamine levels and to keep me from wanting to go back, prevent withdrawal, and all those reasons to break that cycle. So there's a lot of good evidence that helps. The evidence is still out on what to do with children. Are these long-term medication-assisted therapies helpful in children? The jury is still out. Because they're still young and they're still new, are the different things we can try first before we start locking them into some of these medications. There are circumstances where they may truly benefit. Like we've had children, say, with long-term painful ailments or cancers, and we'll put them on buprenorphine, but the jury's still out what to do with those regards. So we've done a lot with opioid prescribing stewardship, which has been good, but it's fun. That's another great graph to show you. So what we've done with opioid prescribing is tanked. Like the amount of opioids that we prescribe patients just dropped dramatically, but the amount of illicit fentanyl use has been skyrocketing. So people are still finding replacements for opioid use. Naloxone, I mentioned that before, engaging people in recovery treatment, long-term treatments we've talked about too. What else did I say here? I forget. But anyway, opioid epidemic. Now here's my AED slide, naloxone. Again, we have not often thought about that, but if you have a child who got into an opioid, it gets admitted, or you have a parent who openly talks about they're on buprenorphine or methadone or some long-acting opioid for whatever issue, there's no harm in giving them naloxone. I think there's a little bit of stigma, like, oh, no, I don't really need that. But you're like, no, this is for little Jimmy. This is for little Susie, right? In case she gets into it again, or he gets into it again, like, you can have this, right? All you have to do is squirt up their nose. So we do have available at the Children's Hospital here. There is, anybody can get it. You can walk to any pharmacy and you can ask for it. Usually it costs you the cost of your copay to get it. There's a standing order. You don't have to prescribe it for yourself. There's a standing order that any person can walk up to a pharmacy that has this and get it filled for themselves. So, and there should be no stigma associated with that to have it available. So that's sort of like a last ditch effort for a lot of these kids. And these are a lot of pie in the sky things. These are a lot of the strategies from the CDC and the executive office about getting community involvement and positive school climates and getting families involved. And I think really engaging parents in terms of the activities of their children are really important. So these are kind of beating the obvious things. But some of the things that you can do as pediatricians, or even physicians, whether emergency medicine or primary care or hospitalist, is there's one screening question that's effective. Are you using marijuana? Are you using opioids? Are you using any drugs? All you have to do is ask, because a lot of times kids, they want to talk about it, right? And sometimes I have kids too, right? They don't want to talk to their parents. They'll listen to their track coach like he's a messiah, right? But I could tell them exactly the same thing. And I'm like, nah, but so sometimes just talking to you, and you may have a captive audience in the hospital. We have a little bit of a captive audience in the office. And I know you have like a million things to do, but studies have shown there's big questionnaires you can ask kids that are really effective. But that single question, are you experimenting with any drugs? That's all you got to ask. You're like, matter of fact, I am. And then that leads the whole conversation about what that means. And sometimes just helping them recognize that you realize using marijuana, means you'll have a lower paying job in the future. Because a lot of times what drives people? Money, a good job, a good career, a good college, a good this, at that age, right? And just telling those little things really helps. Like, hey, kids who smoke marijuana don't go as good at school. They don't make as much money. They don't do, so some of those simple little interactions that we can have with people, lots of negative risk factors too. Lots of trauma in parents' lives. So I think really attacking the opioid epidemic at the adult level will really help our children as well. But unfortunately, with medicinal marijuana, we've had some issues, and I think that's a step backwards for us in terms of fighting that battle because it's so normalized anymore. But I talked fast, didn't I? Because that's it. Kind of through that. So, but 15 minutes to time back. Ray Patetti was going to roast me anyway, so I had to leave some time for that. But, and whether you guys are in the community or you're local here, you know how to page us, go through the Poison Center. If you want addiction resources, we can help you through the Pittsburgh Poison Center, or you can page us. We can help you at the local level. So yeah, there's no harm in calling us regardless of where you are in terms of, looking for resources. Because, it's the pediatric addiction. It's not something that we talk about a lot, and it's not something that we engage our kids a lot about. So it's not as well understood. So if you have questions, give us a call. We can help you navigate it, because it's not easy. And there's, like I showed you, there's so many contributing factors, whether it be environmental or genetic or household related. And sometimes you can't fix everything. It's hard to fix some of these lives that these kids are living in, traumatic households. But you may be able to attack it in different ways. So anywho, anybody have any questions? Any questions come up?
Thank you, Tony. Is this on? Thank you, Tony. That
My
was
pleasure.
fantastic and really useful information for us to think about as we take care of kids.